So it's a pleasure to introduce Dr. Nick Sevdalis, Dr. Stephanie Russ, to talk about one of our big themes, which is the role of teams and teamwork. And they are both psychologists, worked with them both for a long time, and I'm delighted to hand over to Nick to start this first main session.
Thank you. That's brilliant. Thank you very much, Charles. I'm assuming you can all hear me because I can hear my voice quite loud in the background, so I hope that applies to the rest of you. So good afternoon again and welcome to this first annual symposium and the launch event really of this centre. What we thought we would do to kick off this afternoon's presentations is a joint presentation between myself and Dr. Russ, and we're going to be talking to you about teamwork in a very specific context. That is the context of using checklists to improve safety problems and improve teamwork in surgical care in particular. And what we chose to do is to give you a bit of background first, and that's what I'm going to be doing over the next 7 or 8 minutes. And then Stephanie will present to you a collaborative project that we've been carrying out the last 2 to 3 years between the Safety Centre and this trust that we think highlights what can be achieved when you bundle up effort and resource. So straight on to part one, which is the overview. Why do we care so much? Why are checklists so important in healthcare, and particularly in surgery? And this is a slide by one of my colleagues and friends, Krishnamurti, who basically has the very brief history here on checklists. They're not that old. People came up with them, first of all, in commercial aviation. They had a very practical problem to solve. They were making their planes much better. By better, I mean more technologically sophisticated. But as a result, their pilots were forgetting to do things. And unfortunately, some of those omissions were ending up in catastrophic accidents. So planes were crashing off the skies, which was a sort of unintended consequence of that progress. And they thought about something very simple. Why don't we just put a few items on a piece of paper, have that in front of the pilot in the cockpit so they don't forget to do those critical steps? And effectively, one of the experts back in that era said effectively what we're having here is too much of a plane to fly by one man. So to complement the pilot's skills, not instead of the pilot's skills or abilities, but to complement them, and this is an important point, they came up with checklists. So checklists are fairly basic stuff. It's just a list of items arranged in a systematic, so non-random order. And someone, like a pilot, has to go through them to make sure everything is checked and completed if appropriate. So they're there effectively, as I said, to complement pilots' skills, to complement their cognitive ability, their attention, and their memory. Effectively, what they're doing is to introduce some redundancy in the system to make sure that there are safety checks. Interestingly, if you look in the healthcare literature rather than the aviation literature, checklists seem also to be described as means to enhance communication and teamwork within healthcare teams. And we're going to get back to this point shortly. So Charles and Ara have already presented this. We do have problems in healthcare. Every 10 years, we have a major disaster that makes the news. It was Bristol. The pediatric cardiac surgery now is mid-staffs, and maybe there's another one in the pipeline for the next decade. We hope not. But between these disasters and all sorts of other studies in the evolving evidence base, we do know that there's errors and harm that occur within healthcare and that can actually be prevented. And effectively, the checklists are there. If you take this sort of rather well-known view of how these errors and how these accidents occur, this sort of Jim Reason's excuse me, view of accidents and adverse events. You have a risk management system, but there's no perfect risk management system. You've got defenses built into your surgical pathways, but none of these defenses is perfect, and therefore these defenses have holes. On a bad day, these holes line up, and you end up with harm, excuse me, reaching the patient. So what the checklist is doing is basically plugging some of those holes, so it adds to the safety of your system. But in addition to this, if you look at the thinking behind the checklist, and that comes from the WHO, the original developing team of the surgical safety, WHO's surgical safety checklist, the checklist is also there to allow to introduce a standardized, if you like, opportunity for the multidisciplinary team in operating theatre to talk to each other, to double check at the very last minute, just before incision, that everything is okay, just before the patient leaves the operating theatre again, that everything is okay, and so on. So 2 functions at the very least for checklists in healthcare. And there's not one checklist, there's many checklists. This is one from the United States, from Kaiser Permanente healthcare system. And there's, for those of you in cardiothoracic surgery, these are the Society of Thoracic Surgery checklists. They're all freely available to download from their website, inspired, all of them, by the WHO checklist. So what is that checklist? Here it is. Here is the first version of it, developed a few years ago by a WHO working group. Effectively, 3 parts to it. When the patient gets into the anesthesia room, when the patient that's a sign-in. When the patient gets rolled into the operating theatre, that's the timeout, just before incision. And finally, when the operation is complete, just before the patient gets off to recovery, that's the sign-out phase. Fairly simple, but of course the million-dollar question is, not just for this checklist, but for all of them, do they make any difference? Do they make an impact? Do they work? So again, the largest and perhaps most well-known study to date, the so-called pilot evaluation of the WHO checklist, you can see, was an international study, pre-post checklist implementation, fairly simple in its concept, but very powerful across 8 sites. Imperial Hospitals were one of those sites, so data were being collected 2 floors above us, where our operating theatres are. And here is the report of that data set. So that's January 2009, New England, by Atul Gawande, as a senior leader of that group. The key message of this paper is in table number 5. If you look at the number of endpoints for postoperative mortality and morbidity, you find significant reductions across pretty much all the sites that were tested after the introduction of the checklist. This is the headline figure. So the checklist, the WHO checklist, seems to be doing the job of improving patient outcomes and therefore healthcare processes. And indeed, it's not just the surgical world that has shown this pattern of results. It's not just in surgery that we know that checklists improve outcomes. This is just one paper of many now in surgical services. But even before that, for those of you who work in anesthesia and intensive care, Peter Pronovost's group have shown that checklists are quite effective in improving patient outcomes, reducing bloodstream infection, catheter-related bloodstream infection in ITU context. So we know that across a range of clinical domains, these sort of high-impact, high-visibility studies have shown that checklists are effective. So as a result, within weeks of the pilot study data being published in the New England, the National Patient Safety Agency instituted this slightly revised version of the WHO checklist as national policy. So across England and Wales, all NHS trusts, including in all surgical cases, including day surgery, the 3 parts, sign in, time out, sign out, are meant to be done. And within 1 year, all the trusts had to have this checklist implemented, which actually brings us to the crux of this presentation, which Stephanie will cover. Increasingly, we see papers like this in the literature. Checklists are not a silver bullet. There's problems that the checklist cannot resolve. These are problems that relate to systemic issues, cultural issues that are as described, deep teamwork issues in teams and healthcare organizations. A simple arrangement of items on a piece of paper is not going to address those, and indeed it might increase the risk by bringing more complacency to the team that we've done the checklist and everything is okay. So the quality of implementation of the checklist is a critical part of its effectiveness, and it determines, we believe, its effectiveness. And what we're going to do now is we're going to show you how we tried to partner up with the Imperial Trust and improve the way that this checklist is being implemented in our hospitals. So I pass you on to Steph.
Thanks, Nick. As Nick said, we're just going to spend the second half of this session just really emphasising the point that it really is the quality of the implementation of tools like the checklist that determines the degree to which they can realise their potential benefits to patient care. So we just wanted to tell you a bit about the work that we've been doing in direct collaboration with the Trust to try to improve use of the WHO checklist across Imperial hospitals to really embed the tool into practice. And this is still a work in progress, but I think we've come quite far so far. So just to give you a bit of context for this, I thought it might be useful to just sort of mention where all of this work sort of began and has stemmed from. And this was a project that was set up, led by the CPSSQ, funded by the NIHR, which was initiated back in 2009, just after the initial mandate had gone out by the Department of Health for use of the checklist. And this was called the Surgical Checklist Implementation Project, with the acronym of SKIP. And the aim of it really was to evaluate at a national level the implementation of the checklist and how it was going. And we did this in sort of 4 different arms. So firstly, we wanted to look at what were staff perceptions of the checklist. What did staff actually think of the tool? And we did this using surveys and interviews across 20 trusts in England. And we were really here trying to tap into, you know, did they think it was working? Was the content right? Was it usable? That sort of thing. And what were the facilitators and the barriers to actually getting it to work in practice? And then we went into 5 of these trusts and did some more sort of in-depth work, where we actually conducted over 550 observations of the checklist being used in real time, just to see whether it was being used how it was intended to be used and what sort of variation there was there. And then we looked at the impact of this variation on several facets of surgical performance, so teamwork, compliance with processes of care in the operating theatre, and ultimately patient outcomes. And then just to complete the picture, we wanted to know what patients thought of the tool, since they ultimately are the ones who it's there for and are actually involved in it as well. So we did this at Imperial Trust, post-operatively approached patients on the ward, showed them some videos of the checklist being used and asked for their views. Now, I'd love to tell you about all parts of this study, but I thought it would be most useful just to sort of focus in on the local results that we found from this study, and then what we've gone on to do to sort of take this forward since then. So I think really the headline finding, and this wasn't just true for Imperial, this was true across the trusts that we visited, was that really the checklist was not being used optimally, and there was a lot of room for improvement. So from the staff perceptions arm of the study, we found that there were multiple barriers to use of the checklist, and I've just sort of listed a few of those there. So, for example, resistance from certain members of the team, sort of feeling that it was a bit of a threat to professionalism, not really understanding why it was being brought in. If it's not broke, why fix it, sort of thing. Issues with the design of the form, some feeling that it wasn't applicable to certain contexts, such as day surgery, certain surgical specialties, local anaesthetic cases, for example. And what was interesting is that while there were guidelines available from the MPSA online about how to modify the tool, a lot of people weren't actually aware that these existed, and therefore the tool wasn't being modified. And so people were sort of making do with this version of it that they weren't quite happy with. There was scepticism regarding the evidence base and if it applied to the NHS, people feeling that there were actually existing processes in place which it was just repeating. And there was, interestingly, also a bit of worry around the potential negative effects of introducing a tool like the checklist, particularly when it generated a bit of resistance at times, and also the risk of it being used as more of a tick box exercise and potentially creating a sort of false sense of security. And then when we looked at the observation data that we collected, what we found was that while general compliance was quite high, and that's 93% for here at Imperial, but it was pretty similar across trusts, we actually found that when observing what was actually going on the ground, that was quite different. And there was a huge amount of variation in how the checklist was actually being used. So I've just sort of tried to summarise this on that graph. So Imperial's data is there in green, and the red bars represent the average from the other 4 study sites that we conducted the observations in. And you can see there that the first item is what percentage of the items on the checklist were actually covered during the case. And you can see that that was about 2/3 of the items, so it's not being used in its entirety. We then looked at the percentage of cases where all team members are actually present for the checks. And I should say that this data just reflects the time-out portion of the form, but it was quite similar for the sign-out, if not a bit worse. And we found here that really, I mean, at Imperial, less than 50% of cases were all team members actually present for the checks. And in much less than that were all the present team members actually pausing and focusing on the checks. What we tended to find was that it was quite a busy period, obviously, preoperatively. So you got a lot of people in and out of theatre. Sometimes the checklist was initiated before people had turned up. And people were busy getting on with their preoperative tasks. And this variation is important because we really do now know that doing the checklist well is really what makes the difference to patient care. So we found that this variation we were seeing did have an impact on, firstly, teamwork. So you can see from the graph there, the amount of information shared during the timeout portion of the form was positively related to the quality of teamwork later on during the procedure. If all team members were actually present and pausing, and in fact, if the checklist was being driven by the surgeon, we found that teamwork was significantly better during the case. And this was the same for processes and outcomes as well. So you can see there the surgeon leading the checks, less equipment problems, patient more likely to have DVT prophylaxis, antibiotics more likely to be given within that 1 hour before incision. If all team members were present and pausing, this also had beneficial effects for processes. And interestingly, we found that when all 3 components of the form were actually being used, there was a significant reduction in post-operative complication rates. And this just really reinforces the importance of using the form in its entirety. And what we tended to find was that the final sign-out section was often missed. And so, again, it really reinforces the point of including that sort of debriefing and learning phase of the checklist. So what did we actually do with this? Well, we were really fortunate here at Imperial to be supported by the Trust, who gave some funding to actually launch a local project which spanned for a year following the SCIP project, which was a surgical team training project to be run across the 3 Imperial sites. And so you can see there that this project had sort of 2 phases. So firstly, we wanted to focus on improving use of the checklist, and secondly, we wanted to try to introduce some pre-list briefings. Now, that second phase is still very much a work in progress, but we've certainly come quite a long way with the checklist, which is what I'm going to tell you a bit more about. So what did we actually do? Well, we decided the best approach would be to firstly seek our allies and go to those people within the Trust that we knew were really brought into the tool and quite passionate about it. And so we invited these individuals to some workshops which were held at each of the Imperial sites to really just thrash out what they thought was going on with the form, how it could be improved, what the issues were, and so on. And we also provided, a bit of the background data and a bit of the evidence as well. So it was really sort of an education session, but we really wanted their input. And we did some role plays of the checklist, practicing how to feed back to team members following a timeout or a sign-out, how well they thought it had gone, to generate a bit of discussion around it. And then we all agreed that these sort of checklist champions, if you will, would then go back to their normal operating list, and for one case every day, they would feed back to their team how the checklist had gone to generate a bit of discussion around it. But we also felt that it was important not just to target the people that we knew were actually already bought into the form, but to try to target everybody with this message. So we also went to Trust Audit Day sessions and sort of promoted the project there and fed back on the SCIP results. And we actually managed to get all theatre staff into operating theatre to conduct some of these sort of role play scenarios in simulation. We also asked theatre staff, mainly the nurses, to actually self-audit their use of the checklist using exactly the same methodology we had used during SCIP, just to really raise awareness to them how much variation there was in their theatres in use of the form. So what did we find? Well, the baseline data is there in green, and the data after 3 months of this sort of focused training is there in red. So you can see that after just 3 months, we actually found a significant improvement in the percentage of cases where all team members were present and pausing, which was quite unexpected, actually, but really positive. And it shows that we really managed to sort of reinforce the importance of this sort of part of doing the checks. While we were actually on the ground doing the training, we had quite a few conversations with staff, and there were a lot of suggestions as to how the form could be modified. And so we decided to place these suggestion boxes around all of the theatres and in the coffee room, just so that staff could provide anonymous suggestions as to how they thought we could improve the form. And we got a lot of, they just popped post-it notes into the box, and we got a lot of comments back, some relating to the content of the form, wanting the wording to be changed, for example, items to be added, some relating to the layout of the form, wanting somewhere to write a date, wanting sort of yes-no options where applicable. And we also got some more miscellaneous comments, which we didn't really know what to do with. So what we did was we took these suggestions and worked with the designer to come up with a modified version of the form. And this is the first version that we came up with, and it looks like that. So It's set out the same as the original version so that it looks the same, it's identifiable, but it's got all of these suggestions incorporated into it. So you can see there are yes/no options. If you look closely, there are some items added. Pressure care, metalwork, for example, to the timeout. There's a space for a date. And we also utilise the back of the form as an opportunity to provide a bit of education around where the checklist had come from and to really sort of address some of the questions we'd been asked by staff on the ground. So the aim of this was then to trial this new checklist across each of the 3 Imperial sites. And we're still in the process of doing this, but we have done it at Charing Cross Hospital so far in the week at the beginning of June. And you can see there the poster that we put up around Charing Cross to advertise this trial. So we worked with the operating theatre management and the senior sort of band 7 nurses, and we really got them to promote the trial. And then we removed all of the old checklists for that 1 week and replaced them with the new checklist so that the new checklist was being used for every surgical procedure within the hospital. And again, we were there all week doing observations, just talking to people on the ground, getting their feedback on what they thought of the form. And we put the suggestion boxes out. And we got quite a lot of feedback, and it was largely positive. In fact, it was wholly positive. However, there were still some suggestions made for sort of further customising the tool and improving it. And so the aim is really to do this same trial process here at Mary's and also at Hammersmith, just so that everybody gets a chance to try out the new form and to offer their contributions. And then once we've done that, just to come up with a sort of final version of the form that incorporates all of the comments and get that push through governance such that staff are now then using a form that they feel they've got real ownership over, reflects the points that they've made. And we really do hope that that will improve buy-in to the tool. And we're going to sort of do some more observations to see if it actually affects how it's being used, which we hope it will. I'm going to finish talking in just a second, but I just wanted to put that slide up really to remind me as much as anything, just to say that we really do feel that the success that we've had so far with the project, and hopefully will have, has come from this direct collaboration we've had with the Trust and the support we've had from the Trust staff. And we just feel that, this is the reason we're doing it really, is to make an impact on patient care. And that's only sort of since we started working directly with the Trust do we feel that we've actually been able to do that. And I know that we're all quite excited about sort of strengthening this relationship ongoing in the future. So I'm going to stop talking now and just open it up for discussion and any questions. Any questions? Justin at the top.
I'm just going to ask you, you showed a very dramatic improvement after the team training.
Yeah.
Was the sample size the same before the team training? Sampled the same theatres or theatres in which they've been training?
Yeah, we sampled the same theatres. We were actually just in the surgical specialties of general orthopaedics and urology. Obviously, the baseline data which came from SCIP was from a bigger sample. That was 173 cases. And the post-training data was from around about 50, 55 cases. So it was sort of robust enough, I think, to make reasonable sort of conclusions from. Lady just in the middle there again. Yeah, definitely. I'm not sure if it's within this trust, but I know that there are a couple of modified versions out there available for dental practice. So, yeah. Yeah, certainly. I should just mention that this version was sort of to modify just the general form that's used across the hospital, but there's still surgical sort of specialty-specific forms out there, and we really would encourage those to be sort of modified further as well.
Stephanie, I've got a question. You talked about the use of this improving teamwork. So I'd be briefly interested to know how you assess that. But just at a previous hospital, one of the things we found in introducing it was that quite quickly some of the staff, like the ODA and the nurses, got very quickly into the mind frame of asking for their team brief from those consultants, surgeons who were a little reluctant to adopt it as a habit. And it became something that clearly was valued by the team. Is that something that you've picked up when you were looking at the teamwork as well? What difference did it make to the experience of working in theatre of the individuals?
Well, just to start with the first question about how did we assess teamwork, we used, when we did the observations, we stayed for the entire surgical procedure, right from the patient arriving to their transfer to recovery. And we used a tool that was developed here at Imperial called OTAS, which is the Observational Teamwork Assessment for Surgery, which is a validated tool sort of developed from those that were developed in aviation, which assesses a number of teamwork behaviours on a sort of qualitative scale, but it's a very objective and robust tool. So we rated those teamwork behaviours during the case, while trained observers did, and then they could correlate the scores with use of the checklist and so on. And in terms of the last point you made, I think that's a really important point, that it's great that people, nursing staff and the theatre staff, felt that they could sort of stop the case and ask for the checklist to be done. And we did observe that in certain cases. But we also found that it did depend on the personality of the individuals as well, and that didn't always happen. And so we sort of have made a recommendation coming out of this study that we really do feel that surgical buy-in, visible surgical buy-in and driving of the tool is really something that we need to see happening a bit more, so that it's not relying on, you know, certain individual nurses or ODPs speaking out. Do you want to say anything?
There was a couple of comments somewhere there in the middle, so okay.
Hi, thanks Nick and Stephanie. That was a really great presentation. My name is Shweta. I'm an emergency medicine doctor at Chelsea, Westminster, but I'm associated with patient safety. And one of the things that was striking from the two different checklists was the look and feel and the design of the second checklist that felt a lot more easy to relate to. And certainly in our environment, in the emergency department, we are looking at visually creating checklists that look like sort of, you know, kit dumps. One of the things that we do, it's probably one of the most dangerous things we do, is the RSI, or setting up for managing an airway in a very sort of stressful situation. And our checklists are all visual, and we're looking at actually a visual map of all the equipment that should be present before that procedure is undertaken. And we find that that's actually a really useful way, and I don't know whether that was something that was that you felt in any way you visually represented the new checklist, and whether that had any impact.
Yeah, definitely. Did you want to say anything?
I think, yeah, thanks. So I think that's a great point, and to address this, what we thought we should do at this stage, since we did have the opportunity, was to go to a designer. So rather than us putting items, you know, on an A4 and trying to move them around and just make sure they look okay to us, we ask a professional designer to do this. And the form that we've been trialing, the one we had on the slide, is actually produced by the designer. So we've got an ongoing collaboration now with these designers to ensure that whatever we produce from a design point of view, we're following best practice. So it's spot on that it's not just the content, it's how it appears to those who actually use it.